Welcome to Hiroshima University.
Bienvenue à Hiroshima.
広島大学に来てみんさい。
欢迎来到广岛大学。Selamat datang ke Universitas Hiroshima.
Siana Mugela e Hiroshima University.
Selamat datang ke Sekolah Hiroshima Protes Jepun.
Hiroshima 大学に来てください。Welcome to Hiroshima University.
We cordially invite you to be seated at your comfort own table there, because in a few minutes, the ceremony will proceed in no time. May I have your attention, please? Our conference is about to begin. Please have a nice seat in your position and kindly switch your mobile phone to silence mode to avoid interruption. Thank you. Before we get started, I would like to go over some important rules for today's conference. One, please ensure that you have a stable internet connection and are in a quiet environment to minimize background noise, or you can click the mute button in your device. Two, please use the chat feature to ask any questions you may have during the webinar. Our panelists will answer as many as possible, led by our moderator. Please keep all questions and comments respectfully and relevant to the topic at hand. Any inappropriate behavior will not be tolerated. Three, we respectfully invite you to use a virtual free conference JSMID background. And we kindly inform you that our event today will also be broadcast via the Dental Medicine Airlangga YouTube channel. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. His Excellency, the Dean of Faculty of Dental Medicine, Universitas Airlangga, Profesor Dr. Muhammad Lutfi, Dr. Gigi, Magister Kesehatan PBL, and the staffs. The Honorable, the Head of JSMID 7 and Commit 1 Committee, Dr. Irma Josefina Safitri, Dr. Gigi, PhD, Spesialis Periodontia Konsultan, the Honorable all expert speakers of this conference, and respectable all participants of this conference. Welcome to pre-conference online event JSMID 7th Joint Scientific Meeting in Dentistry in conjunction with first collaborative meeting in Implant Dentistry Commit, Thursday, 2nd of November, 2023. Ladies and gentlemen, today's agenda is the online pre-conference before we proceed to our main conference, which will be held for 2 days consecutively, starting from tomorrow and situated in Bumi Hotel Surabaya. First of all, let's thank the Almighty God, Allah Subhanahu wa Ta'ala, who has given us some mercies and blessings so that we can attend this agenda without any obstacles and troubles. Secondly, I would like to introduce myself. I, Muhammad Al-Aqsa Broy Solsasan, undergraduate student of Dental Medicine Universitas Airlangga, will be your master of ceremony in this conference. I would like to thank everyone here to making time to attend this remarkable conference. Ladies and gentlemen, on these occasions, allow me to introduce you to today's agenda. First, we have opening ceremony. Second, we have singing the national anthem Indonesia Raya and Hymne Airlangga. Third, we have session 1 lecture by Prof. Tania. Fourth, we have discussion of session 1. And next, we have session 2 lecture by Dr. Anej. And next, we have discussion of session 2. And then we have online discussion of session 2. And then we can continue with online photo session and then closing. Well, before we start the agenda, let's open our agenda by reciting Basmalah together. Bismillahirrahmanirrahim. Thank you very much. May the agenda run well. Now we are going to the second agenda, deliver our national anthem, Indonesia Raya. Honorable for all audience, pay attention please. Lagu Indonesia Raya.
Indonesia, kebanggaan
Thank you very much. Ladies and gentlemen, now in the first sessions of this conference, we have Profesor Tania Saskianti, Dr. Gigi PhD, spesialis kedokteran gigi anak konsultan from Universitas Airlangga, Indonesia. Professor Tania will talk about at the crossroad of children behavior management. Before we start, I would like to introduce our moderator who will be managing the first and second conference functionality throughout this session from now. Well, our moderator today is Profesor Dr. Dian Agustin Wahyuningrum, Dr. Gigi, spesialis konservasi gigi, subspesialis endodontik konsultan. Prof. Dian, born in Surabaya, 20th August 1971, and for her education, she finished her Doctor of Dental Surgery in Faculty of Dental Medicine, Universitas Airlangga in 1995. And then she finished her endodontics specialist program in Faculty of Dental Medicine, Universitas Airlangga in 2007. And she finished her doctoral program, Medical Science, Universitas Airlangga in 2011. And she finished her endodontic consultant at Universitas Airlangga in 2017. And currently being a professor in Department of Conservative Dentistry, Faculty of Dental Medicine, Universitas Airlangga. Okay, for Prof. Dian, you are pleased to take over.
Thank you. Good morning for our honorable participant and our honorable speaker for today, Professor Tania Saskianti and Professor Dr. Anuj Bardwaj. I will come to the attendees with an invigorating speech, expressing heartfelt gratitude to the guest, speaker, and organizer for their presence and effort. Before we start our meeting seminar today, please allow me to introduce myself as the moderator for today, as I am Professor Dr. Dian Agustin Wahyuningrum. As the moderator, I emphasize the importance of respectful engagement, active participation, and encourage the audience to embrace the spirit of curiosity and inquiry throughout the session. I highlight the significance of the Q&A session and discussion that would follow each presentation, fostering an environment conducive to share learning and the exchange of ideas. Following the opening address, please allow me to introduce our first distinguished speaker, Professor Dr. Tania Saskianti, with her topic, At the Crossroads of Children Behavior Management. Professor Dr. Tania Saskianti, born on Surabaya on 13 January 1977. She finished Doctor of Dental Surgery in Faculty of Dental Medicine, Universitas Airlangga in 2002, and continuing with the Pediatric Dentistry Specialist, Faculty of Dental Medicine, Universitas Airlangga in 2004 until 2007, and continuing with her doctoral program in Hiroshima University at the Biomedical Science and finished 2011, and continuing with the Special Care Dentistry Consultant as the Pediatric Dentistry Collegium. Professor Tania, time is yours.
Thank you, Professor Dian, for the nice introduction. You look more beautiful today, Prof. Dian.
Sorry, because I'm in clinic with my student. Thank you.
Okay. Okay, thank you very much for the nice introduction, Prof. Dian, and also the committee. Allow me to share my screen first. Okay. Okay, can you check my slide? Prof. Dian, is it already clear?
Yes, everything is perfect, Prof. Tania.
Okay. Okay, good morning, ladies and gentlemen. Thank you very much for coming to my presentation this morning. Also, thank you for the committee as well of organizing this very interesting seminar. And Assalamualaikum warahmatullahi wabarakatuh. My name is Tania Saskianti from Universitas Airlangga. And in this morning, I would like to share a little insight on pediatric dentistry. And it is hoped that all of you will understand several concerns regarding the behavior management of the pediatric dentistry. So the title is at the crossroad of the children behavior management. I assure you that you must have meet this kind of patient in lots of time of your clinical practice every day. So we sometimes face with the children with very reluctant to the dental clinic. Further, they won't be entered to the dental clinic. They refuses, they crying, and then you also frightened as the dentist and do know what to do. So the pediatric dentistry behavior management actually is the fundamental of the pediatric dentistry. That important of the behavior management. So the the American Association of Pediatric Dentistry set the latest guidelines on 2020. They said that the successful treatment of pediatric dental patient actually depends on effective communication and developing customized behavior guidance plans dependent on each patient treatment needs. And also it depends on the skills of the dentist. Before we treat the patient, we usually classify the children's cooperation behavior. So several system has already developed for the classification of the children's cooperation behavior. The two most well-known classification is set by Wright on 1975. So Wright divided the children's cooperation into three. The first is the cooperative, and then lacking cooperative, and potentially uncooperative. So we classify the children for the potentially uncooperative if they show the hysterical or uncontrolled, and sometimes they are defiant or obstinate. They don't want to come to the dental clinic. They spoiled, or sometimes the young children that are still timid, still ashamed, and look so anxiety about the dental experience are classified into the potentially uncooperative. We are very well-known classification according to Frankel. So we classified, the Frankel classified into four The first is definite negative, negative, positive, and definitely positive. So the management behavior, according to the AAPD, is the continuous process from basic technique to the advanced technique using non-pharmacological and also pharmacological option for the last option. What is the purpose of the behavior management? Of course, the first is to make the children feel comfortable to receive the treatment, and also by reducing their anxiety, we hope that we can reduce their pain when they receive treatment. And we need to establish our maintenance. So we want to carry out the treatment, dental treatment in dental clinic with the safe procedure. So we can call it the treatment was successful. However, some problems may arise. At first, the parental anxiety and also the toxic stress from the surrounding, from the family, and also sometimes the medical experience of the children can inhibit the success of the dental treatment. And because the children still have an immature psychological development, so they must aware of the dental problems. And also sometimes they have the general behavior problems that can inhibit the successful of dental treatment. So we have to put the triangle pediatric dentistry as a basis that we can provide non-threatening situation. We can provide successful treatment for the children if the parent or the caregiver or the family and the surrounding environment of the children support the children. And also if the dentist and also the dental team and dental environment also give the positive support. So we can provide very nice dental treatment, and also the parent and the children will trust the dental team to give them the dental treatment. In the contrary, if the parent or the caregiver show their frightened, and maybe they sometimes threatening for the children, and sometimes the parents give stress a lot to the children, so the children will feel increase the tension, and also increase the tension also for the dentist and the dental treatment, the dental environment. So we cannot provide a good and comfort and safe dental treatment for the children. So it needs collaboration between the parents or the caregiver or the family with the dental team. So at first we have to prepare by ourselves, and then we can teach the parents, and then we can have the nice dental treatment after we already collaborate with the parents. That is the basic. So the dentist, the pediatric dentist especially, is not a god that can resolve any problems of the children's teeth, but we need to collaborate in order to provide a good dental treatment. So to ensure that we will have a good dental treatment, we use the management behavior. There are two kinds of the management behavior. The first is the non-pharmacologic and the pharmacologic. So let's talk about the non-pharmacologic first. Lots of technique for the non-pharmacologic management behavior. The first is communication. Of course, the success of the dentist when they treat the children are based on their ability to communicate with the children and win their confidence. Sometimes the dentist should, the dentist should show their friendliness, but in a similar way, we have to still have the authority to manage the treatment and to guide the children to follow our order. So the communication can be using the verbal communication and also the non-verbal. For example, we can show the body language. We have to smile. We do the eye contact. We showing concern about the patient. We give them a pet, give them a toss, a hug, for example, in order to make the comfortable communication between the dentist and the children. The second is the tell, show, do technique. So this is a very familiar approach in order to orientate the children for the new element in the dental practice. So we realize that fear is very natural, especially for children. We ourselves, the adult, the typical person, we also fears to things that new for us. And the dental treatment is somehow looks like invasive because the dentist will put something near to our face, so we sometimes feel threatened. So this is the very famous technique. So we tell the children how is the procedure of the treatment will run, and then we show how the dental instrument work, and then we can try this to their body. For example, we use these handpiece, and then we touch the handpiece into their nails, and then slowly we try it without turning on the handpiece. We put it near their mouth, and then we can do slowly, and then the patient will adapt with our technique. The third is the modeling. So the basic modeling procedures involves allowing a patient to observe another patient who demonstrate appropriate behavior in particular patient. So we have to make sure that the first patient that we treat has a nice behavior, so the next patient that check directly, they can adopt the similar model of the behavior. Sometimes the modeling is not restricted on observe the other patient, but also we can show the films, the video, or the poster, or the books, and we can we can say that we hope that you can adopt the similar behavior when I treat you. And then the fourth is the reinforcement. So the reinforcement can be the positive reinforcement. So we can give the rewards if the patient show the desired behavior, or we can do the negative reinforcement by withdrawal or stop our procedure if they show the undesired behavior, or we can give the social reinforcers for the positive reinforcement. We do the praising the child, we show our smiling and laughing facial expression when they show the good behavior, and we do the physical contact by patting on shoulder, for example, for shaking hand, tossing, etc. And we can give the tokens and toys as well for the positive reinforcement. Another technique is the distraction. This is a technique to use to divert the patient attention during the unpleasant procedure. We can use the distraction, for example, the music or using the gadget, or by singing while you're doing the treatment, or doing the hypnosis, and regularly breathing instruction for the children in order to maintain their calmness. For the dentist, we have to know a little, even a little, about the psychological development or stage of the children. So we can give the voice control in order to direct the patient behavior to gain the patient's attention. And we use the voice control to avert the negative or avoidance behavior. So the voice control can establish appropriately between the adult and child roles. So by the voice control, we want to show our authority of the child in order the child to obey our instruction. And we do the retraining. If the child have already unpleasant experience before in the previous dental office, and the child still tends to generalize that unpleasant event will occur in his new dental office also. So this is non-stimulus generalization. We have to anamnesis deeply to the parents. We ask what are the unpleasant experience before, and then we try to avoid it in our dental treatment. So we have to do it more smooth and slowly before we can have the good cooperation with the children. And this is the last non-pharmacological management behavior. The namely is the hand over mouth technique. So this technique actually is contraindicated for the very immature or frightened, or the child with a serious physical, mental, or emotional handicap. I just informed this for you, nice to know, in order to try to not to do this hand over mouth technique. So this method, you use it with our hand or using the towel like this over the child's mouth, and then we persist put our hand and will not remove until the children show the appropriate behavior. Sometimes when the children show their tantrum, they're screaming or they're crying, and then we can put the our hands on our towel until they stop. But we should try another the previous technique first before we use this technique. And the problem is if your patient is a special need patient. Yeah, this is a very challenging situation. Actually, for the psychological view, it is similar for the children or the special need children treatment. So the special need children, maybe it is more challenging for the dentist itself and the dental team, but the special need children still children that need our help. So what are the classification of the special need children? The special need children is the one who has the intellectually impaired, or maybe the impaired of the physics and the sensory, and also the immunogenic, medically compromised, and sometimes the combination of all impairments, and we call it syndrome. However, a healthy physic children, sometimes they also have the dental fear, they have the anxiety, and then the phobia. They called also a special need children, because we need a special treatment and special situation to help and to give the dental treatment for them. The general consideration for treating the dental, the special need children is by planning the treatment. We have to understand the condition. We have to carefully assess and evaluate what is the children dental need and how is their ability and willingness to cooperate during the treatment. So if it is important or if it is needed, we can contact the family physician who treat the patient in order to confirm the diagnosis or the medicamentosa that they already or regularly consume. And it is recommended that we have to do the physical, and then we have to do the intraoral, and then the supporting diagnostic procedure to ensure what is the diagnosis and to plan the dental treatment. And also for the special need children, the treatment planning sometimes different with the typical patient, that we suggest to use the stronger restoration, and then we prefer to use the full coverage of the filling. We also suggest to use the resorbable suture over the other. For example, for the restoration, it is preferred to use the stainless steel crown over the other kind of the filling. And maybe we also suggested to use the glass ionomer cement over the composite in order to have their fluoride advantage. And for the parents, we need to encourage the parents' responsibility at home, because most of the time of the children stay with the parents and caregivers. So it is also their roles to help the children have the nice or healthy oral and tooth area. So the home care should start from infancy, and also we encourage for the parents to do the oral hygiene procedure every day for the children. So this is not independent toothbrushing, but we suggest to do the dependent toothbrushing. So this is the prevention protocol. For the special care children, we emphasize on the prevention aspect of the dental treatment. So the diet counseling, we suggest to choose healthy snacks instead of the sugary snacks. And then we suggest them to have more watering fruits, and then avoid the bottle feeding. And also for the fluoride exposure, for the special care children, it is advisable to give the fluoride exposure more frequent compared to the typical children. For example, if the healthy children has biannually topical application of fluoride, for the special care children, we can make it nearer, so maybe 2 or 3 months for each exposure. And we recommend using fluoride dated toothpaste twice a day, and we also suggest to do the preventive restoration. And all this diet, nutrition, fluoride exposure, and also preventive restoration are not the invasive protocol, so we can suggest to the parents to do these 3 protocols in order to maintain their children's oral health. And of course, the biannually check on the regular professional supervision. So they need to come to the dentist, and we will do the guidance of how to do the toothbrushing, and then we check whether the OHIS or the DMFT regularly in order to maintain the good oral health of the special care children. This is several consideration for treating the children with the special need. At first is the preparation. So we encourage the patient and children to practice the toothbrushing at home, or practice how and do the role play how if they come to the dental clinic. For example, the parents encouraged to keeping the mouth open for a certain time for the children, and then getting used to the reclining position of sitting, and then we can provide the initial pre-visit scheduling without any treatment. We have to do it slowly, so we don't urge the initial pre-visit with any treatment. And we need parents help the dentist to tell stories or visual to the patient in order to them to understand what the visit will involve later. As a dentist, we also have to check the level of the speech, the growth, and also the development of the children. And we have to find out what communication strategies are used daily at home, so we can do the same. After we do this preparation and then assessing the level, we do the desensitizing. So we prevent the intense and unfamiliar sensory experience in the dental clinic that will increase their fear and anxiety by doing the gradual exposure of one treatment. For example, the first visit is to build the familiarity with the staff and the dental environment. And maybe the second visit or maybe the third visit, we can do the specific dental treatment. And to be underlined for the special care children that they have the gag reflex due to their oral hyper or hyposensitivity. So we dentist must flexible and check which one is okay by using the different flavors in toothpaste and can adapt it to the use of the dental tools. So I want to show you all the dental management of all kind of special care children, but due to the limitation of time, I just show you several special conditions that are very common in our daily practice. The first is the visual impairment. So you must be underlined that the visual impairment not doesn't mean they are totally blind. So the visual impairment is the functional limitation of eye, maybe from a low vision to the totally blind. And lots of the dental problem or dental disease arise due to their poor oral self-care. Sometimes they also express the self-injurious habits because of the tension or the insecurity. They do the lip biting like this, or cheek biting, or the bruxism. And because they have several medication, sometimes the medication can induce the xerostomia. And we know that if someone has that xerostomia, it means that it will lead to other problems in their soft oral mucosa. How to establishing the communication for the visual impairment children? We have to talk with the parents or the family first to get broaden information regarding the children, how they communicate, whether using the braille or using the slowly explanation, or how severe or how is the condition, especially for the children. Are they can see clearly, or they cannot see clearly for one eye, etc. And we should speak slowly and face toward the patient. We can use the illuminated room, so we can it is advisable for our room can be illuminated, and we avoid the sudden touch or the sudden loud voice. If they still can see, they can read, we use the large font with the proper spacing between lines, and we should avoid the distraction, and please give the instruction brisk and clear. Check whether they have the alternative ways of communication, so we can be considered about it. For the dental management, the physical access of the room and environment should be confirmed. Please warn the patient before making any adjustment to chair position. And if the patient is sensitive to light, we can offer the dark glasses, but still we have to avoid the shining of light directly in patient's eyes, even they are blind. We explain the procedure to the patient before starting. And if the patient uses stick, never touch or move it before we inform the patient. We can ask where does they want us to place the stick in order to make them secure. So for the dental management, we explain the procedure to the patient before starting. We describe the taste and the smells maybe that can arise, and then we let the patient feel the instrument. So not the tell, show, do, but tell, show, and feel and do. With the assistance, we avoid sudden application of dental instrument. We avoid the dental chair position adjustment without information. We always speak before applying instrument like suction, drill, etc. So we can say, I will put the suction into your mouth. I will take out the suction from your mouth. I will put a dental mirror to your mouth with slowly tempo in order to what is it? If we say the instruction in slow tempo, they will have time to think and adapt with the situation. And the second is the autism spectrum disorder. This is also a situation or the kind of patient that we oftenly face in our dental clinic. The autism spectrum disorder is a group of complex brain development disorder, according to the WHO. So the characterization of the ASD, the ASD is the deficit in social interaction and communication. And the underline is the important characterization of the ASD is the restricted repetitive behavior, restricted and repetitive interest, and also restricted and repetitive activities. If the children has the deficit in social interaction or they have deficit in social communication, but they don't have the RRB, so we cannot name them ASD. Maybe they just shy, maybe they just global development, have the global development, but we can name it ASD if they have the restricted and repetitive behavior. The mental retardation in about 70% of autistic children. They show the posture abnormalities like the picture, such as arm flapping and sometimes the odd posturing, abnormal gait, and resistance upon touching. So they will show the unhappy expression if we ask him to touching or shaking hand or just tapping. They don't like it. So the oral manifestation of the ASD is the caries due to the low texture and poor food, and they oftenly have poor oral hygiene as they are extremely difficult and show the tantrums. And also the ASD has a poor tongue coordination, so they tend to poach the food instead of swallowing, and it will induce the caries on the buccal area. They also show the self-injurious behavior inducing the ulceration. They sometimes have the trauma because of the seizure, and also they have the salivary flow altered, so they have xerostomia. They also show the bruxism and then the erosion and also the bad oral hygiene with the heavy plaque accumulation. Sometimes they show the oral bad habits such as tongue thrusting. And for the very hyperactive ASD, we always found that they have the delay eruption due to the drug-induced hyperplasia. So actually not naturally, but because of the phenytoin, for example, that induced the hyperplasia of the gingiva, and then the hyperplasia of the gingiva will delay the eruption of the permanent tooth. So several things to remember. The communication is the central problems for the ASD, for the dentist and the ASD. So it can lead to very quick frustration for us and hamper the provision of dental care. So we have to make sure that we are ready. The reception area ready, the dental auxiliary, the dental hygienist, and also ourselves. And we have to notice that they don't like crowd. So we have to schedule it when the office is relatively free or not busy. Or we can put it the first queue for the dental appointment. And we have to check what is they like or dislike, what the condition that trigger their tantrum, and what is the expected behavior, and maybe sometimes we can ask the drugs or comorbid they have. We can also ask they to bring their specific toy if they are comfort with this. We ask to the parents to do the desensitization, the children at home, and we introduce the dental clinic with a trip to dental clinic before the treatment. Here is the dental management. We have to give it clear, short, and simple instruction with a very slowly and not intimidating one. We avoid the instrument of children's side, and then we do a very slow and wise. We make sure that the parents are available and the children can see the patient. We do the show do, and then we have to inform whatever we want to do, as the children of the ASD hate surprises. And then we can make a note for all your finding and experience for a better handling this patient in the next visit. And the other kind of special care children is the cerebral palsy. We found a lot the children with cerebral palsy come to our dental clinic. So the cerebral palsy is a disorder of motor impairment with long-lasting effect and non-progressive lesion. We suggest to schedule appointment early morning, and then we have to check the medical records prior to the first appointment, because the cerebral palsy patients sometimes have the medical compromise as well. We have to take the position of them in the dental chair with a comfortable, maybe using the pillow or the beanbag, and we can do the show do modeling. For cerebral palsy, most of them also have the intellectual disability. So we have to show and do very slowly, and sometimes they have also the visually impairment. So we have to accomplish our communication using non-verbal technique. The sedation or the general anesthesia also suggested for this kind of cerebral palsy patient. And the next is the intellectual disability. So the intellectual disability is not the mental illness. So the intellectual disability characterized by significant limitation both in intellectual functioning and also in adaptive behavior, which cover many everyday social and practical skills. AAIDD define that the intellectual disability originates before the age of 18. So after 18, if they have or they show the intellectual disability, it is not intellectual disability. Maybe it is Alzheimer or other diagnosis. And AAMR defines that the upper limit of the intellectual functioning is 70 to 75. So the IQ below this average means they have the intellectual disability. We should do the comprehensive oral examination, and also same with the previous kind of the special need, that we need to assess the level of the growth and development, how to communicate, and then we encourage the parents to do the desensitization at home. And sometimes we cannot ask them to do gargle, so we suggest to use the spray. The patient with the intellectual disability suggested to have the fluoride every 2 or 3 months, didn't suggest it to use the prosthesis, and also the periodontal pack. So it is advisable to use the electrosurgery or laser surgery technique in order to stop the bleeding and increase the length of the wound healing. But sometimes all our non-pharmacological treatment didn't work, so we can use the physical immobilization. This kind of treatment we use to provide the partial or complete immobilization of the patient to protect the patient's safety and also the dental staff from injury. We can use this physical immobilization by the dentist or the staff or the parents, or use the physical restraint using several equipment, for example, the pappus board or the triangular sheet or the pedi-wrap or the mouth prop or bite block. However, we need to have the informed consent of this physical immobilization first from the parents. So the the informed consent is not for the treatment only, but also for the physical immobilization as well. This is the pappus board and the pedi-wrap. We can buy or we can customly design this, and we can adjust with the size of the children. But if this treatment still didn't work, we can go to the second type of the management behavior, that is pharmacologic behavior. So patients who cannot be managed with physical and chemical restraint are the good candidate for the sedation. So we do the pharmacologic management behavior with the sedation first. The conscious sedation is the minimally depressed level of consciousness that retains the patient ability to independently maintain the airway and appropriately physical stimulation. So it means that the patient still conscious, so no lost consciousness. For the autism patient, the sedation or the general anesthesia will perform comprehensive and uninterested and quality dental treatment, providing a long-term prognosis. For the disability intellectual, we use the oral sedation with Valium or Xanax that may be helpful in reducing the anxiety during their dental treatment. And also the nitrous oxide. This is the laughing gas that relaxing, and this is a very quick acting sedation that can decrease the discomfort and anxiety. The onset of action is fast, up to about 3 to 5 minutes, and also this crosses the blood-brain barrier rapidly. But if all the treatment with the conscious sedation still didn't work, we suggest to do the general anesthesia with the interprofessionalism collaboration. So this is one case report that we manage. We meet with a 7-year-old girl who is complaining cavities in her upper right tooth, and the child has been deaf since birth and has difficulty of speaking. So she wear the hearing aid since 4 years ago with a moderate caries risk according to Canberra, and the score of the Frankel behavior scale is 3. So the treatment is we divided the treatment into 2 visits. The first visit is the management behavior only. So we do the show-do technique, not the tell, show, do, using the video and lip reading. And we employ the picture exchange communication system, or PECS, and we do the modeling technique. So the deaf girl, she saw another patient's dental treatment. And with the preparation and management behavior that we provide in first visit, in the second visit, we give her the definite treatment. So based on her preference, the hearing aid was still on during the treatment, and we do the glass ionomer filling on the tooth 55, and then we also do the fissure sealant of 4 permanent molar teeth, and also we do the fluoride topical application. So we can do all this treatment in second visit with the Frankel score is 3. We do the picture exchange communication system. So we prepare several pictures and then we show it to them, to the children. And this is the PECS. We use this dental office vocabulary to describe the children of our planned treatment. And the result, the caries risk is getting low according to Canberra, and the oral hygiene is good, and the score is still 3, but still she can receive the dental treatment very well. So the severely disabled children still actually, even they have very limited conversation ability, still the children can feel whether the dentist has a good attitude or not. So they are very sincere. So we also should to show a good attitude. We suggest to understand the children's characteristic, what are their needs, and the level of the growth and development. We put them in their convenient time in the first place, and we try to seize the world as the patient sees, with a varying level of intelligence, behavior, and understanding. So we have to do the empathic feeling for the patient. We show the firm and friendly attitude for the patient. However, we still have to maintain our authority and address the influence of those to you on the patient's fear. And we have to choose the precise instrumentation in order to give the patients comfort in the dental treatment. So I guess the previous slide is our last presentation. Thank you very much for the time, and I give it back to the moderator. Thank you.
Thank you. Thank you, Prof. Tanya, for the amazing presentation. For our participants who have any question about the Prof. Tania presentation, please to present your question. Any question? I think all the participants full understand about your presentation, Prof. Tania.
Yeah. I hope.
Okay, because there is no question, I think I will to give the resume. We can conclude that children with special needs, defining them as individual experience behavioral, physical, or intellectual challenges, necessitating dentists to adopt their treatment methods. So we need to improve our treatment to understand because they are a special character, need to behavior management requirement in dental setting. And the goal of this section is to deliver effective oral and dental care to support their health and enhance their quality of life. Please give an applause for the Prof. Tania excellent presentation. And I will back to the MC for the certificate session. Thank you.
Well, thank you, Prof. Dian, for the moderating the conference. Okay. Please, everyone give applause. Online applause is okay. Thank you, Prof. Tania, for the excellent and insightful talks. We would like to also thank Prof. Dian for moderating this first session's conference today. Now, Prof. Tania will receive a certificate from Dr. Irma Josefina Savitri, Dr. Gigi Spesialis Periodontia Konsultan, PhD, as the chairpersons of JSMID. I would like to invite Dr. Irma to give the certificate to our invited speakers. Ladies and gentlemen, please pay attention and take a look.
Thank you very much to all participants and for Prof. Tania Saskianti. Thank you very much for your very outstanding presentation. This is a very, give us a very many knowledge and give us a highlight. So thank you very much. And this is our sincere gratitude. We would like to present the certificate to Professor Tania Saskianti as a speaker in the pre-conference online event on the 7th Joint Scientific Meeting in Dentistry in conjunction with the first collaborative meeting in implant dentistry held by Faculty of Dental Medicine, Universitas Airlangga, in conjunction, co-host with Manchester University and Hiroshima University. Thank you very much.
Thank you very much, Dr. Irma. My pleasure.
Okay, maybe we can take some photos. I will count 1, 2, 3, smile. 1, 2, 3, smile. Thank you, Prof. and Doctor. Ladies and gentlemen, please give online applause. Well, ladies and gentlemen, now in the second session of this conference, we have Dr. Anuj Warwaj, PhD, MDS, endodontist from College of Dental Science and Hospital in Indore, India. Dr. Anuj will talk about implants versus our city, which is the winner. Before we start, I would like to invite Professor Dian again, our moderator who will be managing second conference functionality from now. For Professor Dian, we are pleased to take over.
Yes, thank you. Good morning, Prof. Anuj Bhardwaj.
Good morning.
And first I will to read about your CV. Professor Dr. Anuj Bhardwaj graduated from the RV Dental College and Hospital, Bangalore, India in 2007, and postgraduate from Menakasi Animal Dental, Chennai, College and Hospital, Chennai, and currently he is being a professor and head college and dental science hospital Rao Indore. Also as the diplomat of Indian Board of Endodontics, also as a director in the Micro Dentistry Training Academy Indore, also as a director in Bhadswat Dental Clinic Indore. Time is yours, Professor.
Okay. Is my slides visible?
Yes, it's clear, Professor.
Perfect. A very good morning to one and all. First of all, I would like to thank my friend Dr. Deanne for inviting me for this conference where your University of Erlangen, along with co-host Manchester University. It's always a pleasure to be speaking in for Erlangen University. As all of you know, I'm adjunct faculty here, and all thanks to my great, dear, knowledgeable friend, that is Dr. Deanne. She is always the one who has pushed me to do all these things here and lecture around with you people. So to start off with, I would want to ask you, what do you think is better, implants or root canals? See, me being a root canal specialist, I can say that yes, root canals are always better. But the issue is we should have some sound background behind it to know which is the winner. Because off late, what's happening is everyone is jumping into implants. They do not think before doing anything. They just think that extraction is an easy way out. Just remove the tooth, just place an implant and restore the implant. But the problem is we are not understanding that what goes behind implants and what goes behind root canal. It's very easy to remove a tooth, place an implant, but then coming to the restorability, understanding the occlusion, understanding that there is going to be no periodontal ligament tissues, which is going to give you a warning or a proprioception where how much of force or how much of intensity of force has to be applied. Whereas in root canals, what's happening is it might be technique sensitive. It might be a little difficult to operate on, but yes, you're saving a natural tooth. So if you save a natural tooth, you are giving an extra life to the patient. How do I mean that you're giving an extra life? I mean to say that over a period of time, even if a root canal treated tooth stays for a decade or so, you still have a second chance of an implant. But if you've placed an implant, what is your next option if it fails? That's my question to everyone. So we need to understand the longevity which an implant has or which a tooth has. We need to weigh it out. It's always better to repair or to make sure that you go towards healing rather than just being very impatient and removing the tooth and going ahead with an implant. But then I have a lot of people who say that implants have better benefits. The patient doesn't have to keep coming again and again. Patients want a perfect protocol or they want immediate results. Agreed. Implants are very good in an area of edentulous cases. They are very good when you don't want to cut down or you don't want to prepare vital teeth, especially for your single tooth missing, you don't want to do an FPD. Yes, in these cases, they turn out to be really well. But I would suggest don't go ahead and remove the tooth just because you are not able to tackle the difficulties or the anatomy, or in retreatment cases where you're not able to reach the apex. So if proper guidelines are followed or if it is reaching the specialist, I don't think root canal in 90 to 95% of the cases is an issue. So these are the few terms which have come into market. I would say market because it's not for specialists, or it's not for from graduation point of view. We never heard something called as survival. Now, there's a lot of comparison of success versus survival. And this is basically, it has been introduced after implants have come into the picture. Because with root canal, it was just the healing of the root canal. That was very important. But when it comes to your implants, they talk about the implant being osseointegrated with the bone, it having peri-implantitis or not having peri-implantitis. Initially, people did not understand what is this radiolucency, which is happening or occurring around the implant. Sooner or later, they came out with this peri-implantitis terminology, as we have it in our endo, which is apical periodontitis. Any inflammation around the implant, they named it as peri-implantitis. Then they started considering the loss of bone occurring around the implant, because survival meant that even if the implant is hanging in the mouth, it is considered to be successful comparing it with an endodontic treatment. Because we all endodontists, even Dr. Diane for that matter, we are very, very strict in judging the tooth being successful or not, whether it's having good healing or not. And same thing follows with the criteria which are given. Whereas the criteria which were given for osseointegration by the Academy in 2010 was still not very clear, because the amount of variation these implant society have given is, it might include, that is, implant mobility, inability to restore the implant, a patient having persistent pain, neuropathy if it is very close to the nerve or you have caused some compression to the nerve, there is loss of function, or there is constant or persistent peri-implant radiolucency, you're having progressive bone loss, which is not actually felt or understood by the patient, but we understand it when we are taking our radiographs. On a regular basis, when you're calling these patients, you are having bone loss. There's progressive bone loss, as well as when you're taking your periodontal probe and checking for probing depth, it's increasing over a period of time, as well as the prosthesis is becoming unstable, or it's becoming mobile every time the patient comes in. The patient says, I went for an implant, you've tightened with the screw, or you've given a luted prosthesis, but after every month or every 45-50 days, the prosthesis is becoming loose. So what's going wrong? Where have I gone wrong? And in very few cases, initially, I would say 2 decades back, we had implant fractures also. So till date, they are not able to come to a conclusion what criteria have to be defined to understand the exact successful implant therapy. Now, another thing which we need to understand is, as I discussed in last 2 slides, was the criteria. The criteria which have been used for understanding implant success or its survival have always been very lenient criteria. Whereas in endodontics, we have a lenient criteria as well as strict criteria. And as you all know, we always follow the strict criteria of understanding whether the root canal treated tooth is successful or not. We wait for 3 months to see the radiolucency coming down. Initially, in a week or 2, we do have the pain, discomfort. Any problem? I'm hearing noises from the background. Is it all okay? Can I continue?
Hello? Yes, you can, Dr. Anuj. Perfectly well.
Thank you. So when it comes to the strict criteria for us, someone's mic is on. Can you please? Thank you. Okay. So understanding the criteria for success and not survival, because in endodontics, we have only success. We don't talk about survivable. It's not that the tooth is just there in the mouth. It has to be functional. What is the reason behind doing a root canal is so that it can take up a post-endodontic restoration. That means it can either take a crown, inlay, onlay, or it should be in a condition where it can be used for chewing and biting. But that's not the case, and that's not the criteria which are being followed for implants. So there have been a lot of systematic reviews and qualitative analysis which have been spanning over 20 years, and here they talk more often about survival than success assessment. So there's nothing wrong in doing this, because implants are comparatively new to root canal treatments. But if you see here, which they talk about the success or the survival analysis, in which they have done, they've taken more than 1,000 implant teeth over 6 years, and they have seen a survival rate of 92.2%. But if you see, you have to be very clear about understanding survival as well as success. The success rate has been only 83.4%. So survival is it staying there. Success is it staying there and helping you do the function, form and function. I am not talking about aesthetics yet, because aesthetics would be a later perspective. Whereas there is another study where they had cumulative implants, where they have talked about single tooth prostheses, cantilever prostheses. Initially, they tried a lot of permutation and combinations, where they had an implant supported cantilever, or they had a bridge with a natural tooth and an implant. Later, they realized that because of presence of PDL in a natural tooth, and implant not having PDL and not having proprioception, the bridge would fail. So those FPDs and prostheses were taken off. So if you see here, the success rate was as low as 63% for such cases. So we need to understand whether just survival or success is important. So now this makes it very difficult to compare this endodontic outcome with these ill-defined criteria which are given by implant group. And what we need to understand again here is that same comparison of success, not survival, when this was done for more than 1.4, if you see 1.4 million teeth, which had primary endodontic treatment and which were followed for more than 8 years, the success rate was 97%, whereas 3% of these needed retreatment or extraction. But of late, people are little inquisitive or little doubtful about retreatment. They think that tooth removal and implant placement is much easier. But I would say a retreatment or a periapical surgery will still give you better results and will give you enough bone formation in and around it, which can lead to which can help you in later stages, like a decade or 2 decades later, for an implant site formation. So same way here, a very good study done by Iqbal and Kim. Now, why do I always quote these two people are? Because they are endodontists who do a lot of microsurgeries, and they understand that root canal treated tooth which has failed, they give second life to it, and the success rate which they have is more than 94%, which is actually better than the survival rate of implant. So you need to understand what is a prognosis of an implant. So again, see, I'm bringing a lot of terms: success, survival, prognosis. Now you need to understand why we talk about prognosis here, because initially we had a single stage implant, then we had 2-stage implant, we have immediate implant. These are very confusing terminologies, but if you pay attention, they are very, very meaningful. They give you a lot of insight about what's happening and what we should be doing as a general dentist or a root canal specialist. So here on prognosis of implants, there's a meta-analysis which found success rate of 96 to 97% for a single unit restoration. And it found a success rate of 90 to 93% when you had your partial restoration, fixed partial restorations for 6 to 7 years. So if you see, the success rate is coming down, not survival rate, the success rate. And we're talking about single unit restorations. Whereas when we had a large scale study for the success rate of 13,000 2-stage implant, where you place an implant, you wait for the osseointegration, then you place your prosthesis over it. For 15 years, they got a success rate of 85%. which was comparable to a single stage surgery implant over 10 years, which had few failures as well. So you need to understand what is ailing or failing implant, because what these implantologists see, mainly there is no different branch called implantology. It's your general dentist or your periodontist or your oral surgeons or even endodontists. They are the ones who are doing implants. So what is ailing and what is failing? You need to understand this. This is a very, very important statement when it comes to understanding how good an implant is or how good your root canal is going to be. So here again, we are going to be comparing that a long-term survival rate of implants without any technical complications. So technical complications, and as I had mentioned about the criteria which the association has given in 2010. So if you exclude them, the success of the survival rate can range from 75 to 85%. So what you need to understand here is, this is a very, very important statement which I'm going to be mentioning. Even after the completion of craniofacial development, implant placement in young adults therefore may be viewed with caution, because the restorability options in areas where implants were previously lost have yet to be explored on higher evidence level. So if there is a growing maxilla or a growing mandible, still we do not know that the placement of implant is going to have a success rate or not, whether we are going to have this implant fail, because your arch form is going to change, your bone plasticity is going to change, your arch form is going to change, your occlusion is going to change. So implant is not always the option in all the cases. So these are the things which you need to pay attention and you need to understand. And most importantly, you need to understand is, you have a lot of funding which happened and a lot of studies which were proposed way back, I would say 2 decades back, in around late 2010s, where they spoke about that you had a good success rate of 90 to 95%. But the problem was these 60 to 63% studies were all funded and they were not disclosed. So of late, if you see the acknowledgement which is there in any article, it's very clearly mentioned who is the part of that. So it's like in my university, if a student from my university presents a case, he would say the success rate is so and so. And if there is a student which produces a case from your university, they would say this is the success rate. But there is going to be a bias there, because you're always going to be bent on showing good results from your university or from your institution. And it is going to be more evident if you are having some financial interest or gains. So this is what we mean by funding. So most of the implants which came out initially were from very big companies, and they had a lot of funding towards carrying out this research, or they had a lot of sponsorship for the colleagues doing this. So the bias of success or survival in comparison to endo was very, very evident. And that is what we need to understand, that we need to have strict inclusion and exclusion criteria to understand whether you're going to have success or survival of an implant. I agree the general dentists or the students who are listening to my lecture would slightly be confused and bored in today's lecture, because this topic is one topic which no one likes to speak on. The reason being that everyone wants easy way out, everyone wants fast money, everyone wants easy success. But what you need to understand is, on a longer run, it's not about gaining finances now. On a longer run, if you're having a practice of more than 15, 20 years, and when these cases come back to you, and those cases stop believing in you because of your ideology or you being biased to one treatment, is going to cause a lot of issues. So this is the reason I took up this topic, and I'm trying to throw some light on it, because you need to understand the habits or the predisposing factors which are going to play a role when you're placing an implant compared to managing the tooth which is there in the tooth. So especially in these cases, if the patient smokes regularly, has alcohol consumption, has very poor oral hygiene, has type 4 bone, which will not hold on to the implant for a longer time, has a lot of parafunctional habits, or bruxism. Very few of us pay a lot of attention to occlusion. See, occlusion is the one which is going to decide whether your natural tooth or a root canal treated tooth is going to last in the mouth or not, as well as it's going to decide whether your implant is going to last in the mouth or it's going to cause trauma to your opposing tooth. So you need to understand the patient pool which you're going to be addressing to, or the general population where they're going to have this parafunctional or these habits, and how you're going to be treating them. So you need to understand which patient you need to exclude and which patient you need to include in this terminology of doing implants. So now there was this wonderful study done by University of Minnesota by Doyle et al. In way back in 2006, where there was no sponsorship or there was no bias in this, where they have compared endodontically treated teeth with single unit implants. And to our surprise, you would find that the positive outcome of 74% for implants and 84% for endodontically treated teeth. Here we are not talking in the range of 95% or 97%. See, what happens is, if an endodontist is carrying out a study, they will always have a bias towards giving results which are very good for endo. Whereas a person who is more bent towards implant and they carry out a study, they would give a better, there is an unknown bias always. But if a third person who is slightly neutral and does the study will give you exact values, like here, it's a very impressive study which gives you a range of 74% to 84%. There's nothing like 95% or 97%. If you read Engel or Cohen, it says you have success rate of 95.4% and above in over a period of 10 to 15 years. Whereas if you read a lot of books on implants like Mish and those ones, they say you have a success or a survival rate of 97% over a range of 10 to 15 years. Now, to your surprise, we have these mono implants. We have basal implants also. Cases where there is less bone, there is no enough structure for the implant to get in. You have these basal implants, or you have your plate implants, which can be wrapped around the basal bone and they can be used. But you need to understand anything and everything which is placed in the mouth. You should have a non-biased opinion of more than 20-25 years for us to come to a conclusion whether what is happening in the oral cavity is right or not. So what is the decision you need to make? And can we make these decisions, or can we put across these decisions to our patients based on these outcome analysis? I would say no. Reason being, all the studies which were carried out till now, or all the researchers except few, they all considered, or they had some funding, or they had bias. And people who are doing implant practice for more than 10 to 15 years, or who are doing root canals and retreatments for more than 10 to 15 years, I'm sure the results which you have got in preserving the natural tooth over replacing the natural tooth, you yourself can answer to yourself. You would not need a surgical survey for that, because the prognosis of an endodontically treated tooth, as by strict criteria or the systematic reviews or the meta-analysis which have been done way back in 1950 and 2000, and to your surprise, these all were done by pre-doctoral students or doctors who lacked experience. But with the technology which we have, with the material which we have, with the clinical acumen which is given to us, and the research which we have now, I'm sure these success rate of 81% or 90% can be increased, because initially, what are the materials we were using? What are the file systems we were using? What are the irrigants we were using? What were the magnifying devices we were using? Did we have CBCTs? Did we have micro CTs to give us the actual anatomy and the anatomical predilection in population? Did we have all this? No. And these are the researches which we are paying attention to and trying to follow. So their long-term healing or their success or survival was good a decade back. But now we need to start afresh and need to understand that we need to have a non-biased, strict criteria for implants as well as for endodontically treated teeth. That is very, very important. So the old and new techniques in endodontics and implantology also, I would not say only in endodontics, even in implantology, we have different types of threaded screws, we have different types of covering, you have different types of osseointegration materials put up, you have those threads, you have screws, you have rough surfaces, there is an endo, you have magnification, you have activation devices, you have sonic irrigation, you have gentle wave, you have lasers. Whereas even in implants, you have laser guided or guided surgeries where you do not even reflect a flap, you do not have any what you call extra damage being caused to the surrounding tissues. So yes, the success rate is going to go up, but you need to understand that with microsurgeries, with retreatments, advancement in these, we can actually save the teeth where you feel only extraction or surgical, non-surgical retreatment. People always go for the first option when there is a primary endodontic failure. They just go for a CBCT and they say that, yes, there are ledges, there are perforations, there's an instrument which is broken at that apex or which has gone beyond, and there is a huge cystic lesion. It can be a true cyst or a base cyst. We do not know till we explore it. So if you're going for a non-surgical intervention, that's a non-surgical retreatment, orthograde treatment, there are very good chances, around 80 to 85% here, you're going to have success. But yes, if the apical sealing has not happened, you're having a big cyst, you can still go for a microsurgery. The next question comes is, if the lesion is big, how can you do a microsurgery? The size of the window or the removal of the cyst is going to remain the same. What you need to understand is the approach, the removal is going to be as minimal as possible when you're using a magnification device. You would not be like a butcher. You would not remove any excess. You would remove as minimal as possible, which is adequate enough to cause healing and cause a repair in coming times. So if this does not happen, like for an instance, let me tell you about a crown root ratio where the crown root ratio is not helping us. There's a big lesion. We have done the curettage. We've done everything. There is bone formation, but we know sooner or later the tooth is going to become mobile and come out. But you do not understand that the bone which is formed there is going to be a site for an implant. So in case where you had removed the tooth, you had done your enucleation, you had packed in your implant, you had packed in your bone graft there, you would not have an ideal torque for it to stay there. And it would take a longer time for this implant to get attached or get osseointegrated. Whereas if you had this tooth in the mouth, it would survive. Plus, even if it did not survive on a longer duration, it would have helped in bone formation, which could be the best site for an implant to be placed. So it's always a win-win situation when you're going for a non-surgical or a surgical retreatment. So this is one very, very important aspect which we need to understand. This is nothing against or for anyone, but what we need to understand is a practitioner who is into practice for more than 30 years, a practitioner who is into 20 years or 10 years, they all have their shortcomings, they all have their lacking. Because a practitioner of 30 years back would still think that rotary endodontics is the advancement. A person who is practicing for the last 20 years would think, yes, implants have come in, we can think of placing an implant. A recent dentist would say, yes, I can do anything under the sun, whether it's an implant, whether it's surgical, non-surgical, I've got the magic. What we need to understand is we need to change our mindset. We need to have a firm background and knowledge and clinical data about understanding which treatment is going to be better for which case and which patient, understanding the tooth, understanding the bone quality, understanding the most important is the oral hygiene, because 30% of the people feel that necrotic pulp has higher success rate than implants, which is actually right. But the middle ones feel no. Now, where we need to understand or what we need to put across here is the periodontal and restorative aspect. This is what I've been talking about. And this is what you need to pay a lot of attention to. So, perio, endo, or prosthetic, you need to understand the foundation, the gums, the bone, the periodontal ligament has to be conducive enough for the tooth to stay or for the implant to come in. And the aeronautic status, if you're making sure that the same tooth is there, whether it is good enough, so that sooner or later, whether you've placed a tooth or you're working with a natural tooth or you're working with an implant, you need to give prosthesis, right? That is very important. Why are you doing all this work? So that later you can place a prosthesis and you can actually chew onto it and bite onto it. But what we do not understand is the crown root ratio, the crown and root fractures, where what is going to happen, whether if you are having less tooth structure, can crown lengthening help? Can orthodontic extrusion help in these cases? Why do we have to think that yes, there's a lot of loss of tooth structure? Easy way out is rather than giving a surgical extrusion or an orthodontic extrusion or doing crown lengthening and waiting for so much time, I just pull the tooth out and place an implant. You need to understand what patient wants. And above all, you need to understand what are the financial constraints the patient might face, or what financial issues you are going to put across, whether the patient is going to be able to afford that much or not. That again plays an important role. So before I come to end of my presentation, yes, it's a short presentation, but here what I would want to say here is I would read these line by line, because I've taken this from an article which actually changed my mindset also for implants. I'm an endodontist who does a lot of endo. I try saving each and every tooth. But then I realized that not every tooth can be saved. Now, what do I mean by this is these take-home messages. You need to understand the market strategies and the economic forces have resulted in ongoing commercialization of clinical practice. Now, let's talk about root canal treatment or aesthetic treatment followed aesthetic or a restorative or a prosthetic treatment following a root canal treatment. So if you see, we are slowly becoming market driven. Now, what do I mean by market driven is the companies come and tell us, if you use this kind of taper, if you're going to use these three-dimensional files, you're going to have less tooth cutting from inside. And the tooth is going to have less micro cracks. We've never been talking about these micro cracks till now. First thing. Second thing, if you're going to use this kind of restorative material, the bond strength is so high that you would not even need an onlay or a crown. The compressive strength of this composite is that high. But what we need to understand is the eating habits. Because the researches which are being published are from one region. Now, I always believe this, and I always discuss this with my colleagues, is people who are having saturated food or who are having just breads have a different kind of eating environment. The kind of food I eat in my population, in my region, is different. And the kind of food you're eating in your population is different. So the fiber, the tensile and the compressive strength required to bite and chew that food is going to always vary. So you just cannot have one biased opinion just because one researcher from one country has given you that, because their eating habits or their way of living life is different than ours. So this is one thing which you need to pay attention to, whether it's an implant or you're trying to save the tooth. Dental education becomes dominated by companies rather than by educators or experienced clinicians. Or if fewer cases are handled by specialists, we must be surprised when the number of implants or endodontic complications and failures will increase. So this is the second reason which I say don't always follow social media. Have a research or read a research or listen to your senior or a guide or a teacher who has a vast experience and is not biased by the companies. They're going to tell you what is going to work in your favor. So for example, if I put up a social media post saying that this material is very good and you're not going to have any failure rates, the success rate is going to go so high. So people who follow me or people who listen to me are just going to blindly follow it. But do you people know that I have been sponsored or there is someone who is paying me to do that? So that's not evident there. Or is there any financial interest or gains? So this is the reason why we say you need to attend these kind of lectures. You need to attend more CMEs and CDs where you're having continued dental education where they give you raw facts of different populations. So if you see, now you're having multi-centric studies for everything, because just because of one region, you cannot come to a conclusion that, yes, this is the kind of predilection or this is the kind of success or the failure rate you're going to have. So this is one thing which you need to understand very well. Now, even with the survival rate of implants, if an inexperienced practitioner places an implant who does not know how much torque, what angulation, how much of bone needs to be covered, or how much of implant screw or implant threads need to be covered or exposed, they will have a success rate of 73%, which is actually less than a root canal done by a inexperienced general dentist. Whereas a same implant is placed by a specialist. For me, an implant specialist is a one who understands soft tissue, who understands bone, who understands the mechanics behind it, because there's a lot of mechanics and physics in implant. If you do not follow the long axis, you do not follow how much load has to be given onto it, the implants are always going to fail. And you would have seen so many cases that they place an implant, but in the end, the prostheses are very shabby. They have angulated abutments. So the more angulations, the more junctions you're going to have, the implant is not going to last for very long. You're going to have a lot of repetitions. You're going to have increased bone loss. Whereas if you do root canals, whether it's done by a endodontic specialist or even a general practitioners also have got a success rate as high as 89%. Whereas a specialist dentist or endodontic specialist who has adequate experience has got a success rate of up to 98.1%. I would say let's not take it 98%, let's take it 95.4%, as mentioned in England Cohen. That is still very, very good. I'm sure this is one statement which every patient all around the world says, what is the guarantee? What is the warranty you're going to have? We need to understand that there is no lifetime guarantee or warranty of any prosthesis given or a natural tooth. We do not know when and how an implant can fail, but we do know we can increase the life of these provided we understand what is good and what is not good. So now coming to the end of this presentation, I would like to say both options should be complementing each other rather than competing. So when an implant is required, you should go ahead and place an implant, but not at the cost of salvaging a tooth which could have been saved and later feeling bad or guilty about. Because in the end, you need to understand form, function, aesthetics, as well as comfort. Comfort is very, very important. Of late, patients want more of comfort than function and a lot of aesthetics. So things are changing. You need to understand in this post-COVID, we have understood that everyone wants very good aesthetics. Everyone wants comfort. And along with that, they want function and form. So these goals can be achieved on a long term, provided you're having a person who thinks neutrally about or thinks in favor of a patient. Just think, it's your jaw, it is your tooth. Whether you would save your tooth or would you go for an implant? That is very, very important for us to understand, because short-term gains can lead to long-term loss. Because what happens is, sooner or later, the teeth which could have been saved, someone or the other is going to say, why didn't you save the tooth? Why did you just go ahead for an implant? That natural tooth could have been saved and you would have had longer life with a natural tooth. People who are listening to my lecture, I'm sure few of you might be having implants also. So those people, just talk to them and ask them, how does a natural tooth feel and how does an implant feel? Implant will always feel like a foreign body. You will never have a proprioception. You can actually bite onto anything very hard, and you would, until unless you're having an opposing tooth which has proprioception, your implant will not give you proprioception, but your opposing tooth will tell you, no, don't give so much of pressure, don't give so much of load. There have been instances where you're having implants opposing each other, and there has been a fracture of mandible or of maxilla because of giving inadvertent extra forces, because they did not know how much force is enough or how much force is too much for the bone or the bone surrounding the implant to fail or to fracture. So coming to the end of my presentation, I would like to thank you all once again. Sorry for being very short and sweet here in my presentation. The reason being, this is one never-ending topic. We need to understand where to weigh out and what to do, and come to a conclusion right in between that, yes, the patient is above more than the finances. What works in their favor is what we need to decide. And as I said, coming to the end of my presentation, this is as read out in my resume or CV. This is a place where I've done my undergraduation. This is a place where I've done my post-graduation in Chennai. And here I had got trained for my advanced microdentistry in Germany. And this is a place where I teach my postgraduates whatever little I know. And this is the team of postgraduates which I work with. And one thing which I would like to stress upon to all my students and all the people who listen to me and all the colleagues in and around the world, it does not matter how many resources you have. If you do not know how to use them, it will never be enough. Now, what do I mean by this is, this guy who's standing there, he could have just used one ladder to climb and go across the wall or see what's happening across the wall. But what is he trying to do? He's making a heap of these ladders and trying to see. So same thing comes with implants and endo. If you understand what is required, when it is required, and how it is required, you will never fail to amaze yourself. Leave the patients. So thank you, my teachers, my friends, my mentors, and a special thanks to you, Dr. Deanne. You've always been a good teacher, mentor, and a very good friend to me. And I always acknowledge and respect our friendship. Thank you.
Thank you, Prof. Anuj, for your amazing presentation. And for our participants who have the question, please do not hesitate to present your question. Yeah. Okay. Any question?
They've not understood anything. That is why they're not asking questions.
Okay. Thank you. Implant versus the root canal treatments always make a debate because depend on the case selection and some of consideration due to the what is the patient needed. So this is very difficult because to compare the endodontic outcome study with the strictly defined success criteria with the implant outcome database on survival. If a positive outcome for teeth was defined a retention without symptom, regardless of the periapical stages, the survival of endodontically treated teeth is as high as the compared with the implant. Thank you, Prof. Anas, for your presentation. And for the certificate session, I will come back to the MC.
Well, thank you, Prof. Dian. And ladies and gentlemen, please give online applause. Thank you, Dr. Anuj, for the excellent and insightful talks. We would like to also thank Professor Dian for moderating this second session's conference today. Now, Dr. Anuj will receive a certificate from Dr. Dini Setiawati, Dr. Gigi Magister Kesehatan PhD, as the Deputy Dean 3, Faculty of Dental Medicine, Universitas Airlangga. I would like to invite Dr. Dini to give the certificate to our invited speaker and to Professor Dian as moderator.
Thank you.
Okay. Okay. For all the audience here, please wait for a second. Okay. I would like to remind you again that tomorrow there will be a main conference and hands-on of JSMID 7 and Commit 1 at the Bumi Hotel Surabaya. So don't miss it out. For you all, that tomorrow there will be a main conference that and hands-on of JSMID 7 and Commit 1. So don't miss it out.
Okay. Thank you so much for Prof. Anuj Bharadwaj for your very interesting topic in this pre-conference for JSMID and Commit this morning. We really appreciate your willingness to be our presenter in this pre-conference. And we hope that we can have another collaboration in the near future. And as a token appreciation, we would like to give you a certificate of appreciation to Prof. Anuj Bharadwaj as a speaker in our event. Thank you, Prof. Anuj Bharadwaj.
Good afternoon. My pleasure.
Okay, hold on, Dr. Dini. We can take some photo session. I will count down. 1, 2, 3, smile. Again, 1, 2, 3, smile. Okay, thank you, Dr. Dini and Dr. Anuj. And for Prof. Dian, we can take some photo sessions. Okay. Okay, and now is giving certificate to Dr. Prof. Dian as a moderator by Dr. Dini Setiawati.
Okay. Thank you also for Prof. Dian Agustin Wahyuningrum for inviting Prof. Anuj to this pre-conference as a speaker and also to facilitate this event. I mean, for the pre-conference for Prof. Anuj session. So as a token of appreciation, we would like to also give Prof. Dian a certificate of appreciation as a moderator for this session. Thank you, Prof. Dian.
Thank you, Dr. Dini.
Okay, ladies and gentlemen, please give applause again. Finally, we have been in the end of today's conference. Before we say goodbye, I would like to invite you to open your camera and take an upright and comfortable position, and we can take photos together. Okay? I would like to invite you to open your camera, your Zoom camera, and we can take some photo session. Okay? Ready? I will count down. 3, 2, 1, smile. Again, 3, 2, 1, smile. Okay. 3, 2, 1, smile again. Okay. I want to remind you again that don't forget to fill the presentation for the absence today. That will be attendance list and your Google Form, and you can check for the comment below on your Zoom. There is a link for you all to fill it. Okay, the attendance form is ready to fulfill by you all the participants here. And then, okay, we believe that the information presented here will be beneficial to all who attend. We hope that this conference will inspire us in this dentistry world in this future. As we come to the end of our conference, we appreciate your time and hope to see you again soon. I kindly remind you again that tomorrow there will be a main conference and hands-on of JSMID 7 and Commit 1 at the Bumi Hotel Surabaya. I am Aksa. As a master of ceremony from my deepest heart, I do apologize for my mistakes in this conference. Thank you so much for the attention and the willingness that the audience have to attend the pre-conference. Last but not least, I have an Indonesian poem to you all. Buah nanas, buah ceri, dicampur gula enak sekali. Cukup sekian acara kali ini. Semoga bisa bertemu lagi di kemudian hari. Wassalamualaikum warahmatullahi wabarakatuh. Alhamdulillah.